So let's get started with prerenal disease. And remember, prerenal is really a hypoperfusion. We'll talk about the etiologies, the patient presentation, and the treatment. But as we talk about prerenal, it's really important to understand the pathophysiology. When our body senses hypoperfusion in the system, how we respond to it really helps define AKIs, especially prerenal AKIs. And it also plays a role when we talk about the drug-induced causes. So let's just make sure that we understand the lay of the land. You have the afferent arteriole that feeds blood into the glomerulus, and then the efferent arteriole that takes it away. And here we have what's called the JGA complex. It's actually the juxtaglomerular apparatus. What this does is it really helps control the hemodynamics of the glomerulus. The reason this is important is because actually the RAS system is embedded in this JGA complex, or the start of the RAS system, where renin will actually be released and cause angiotensin II to flow throughout the system. So, when this JGA apparatus senses hypoperfusion, renin is released. That's that first part of that renin-aldosterone system. This causes AG2, or angiotensin II, it's actually AT2, to clamp down throughout the entire body, but specifically here at this efferent arteriole. Now, this clamp down throughout the body will increase sympathetic activity and increase vasoconstriction throughout the entire body. But here at the efferent arteriole, you can think of this as like this glomerulus really is kind of like a hose with a bunch of holes in it. And whenever you would tamp down on this, it's like stomping down on a hose with a hole in it, and it's actually going to increase the amount of pressure that comes out of this glomerulus, thus trying to maintain this normal perfusion. Also, as part of the RAS response, antidiuretic hormone is released. This is increasing thirst and increasing sodium and water retention. Because remember, wherever sodium goes, water goes. So we're going to make sodium and water stay in the body and increase that retention. At the same time, this GGA complex also releases nitric oxide and prostaglandins. And if we remember inflammatory responses and then also nitric oxide, they're both cause vasodilation. And it's going to cause vasodilation right here at the afferent arteriole. This allows more blood to enter the system while you're tamping down on this efferent arteriole. Now, these both play an important role, this A2 vasoconstriction and this nitric oxide and prostaglandin-mediated dilation, because this is the mechanism of both NSAIDs in the case of this prostaglandin and ACE inhibitors and ARBs in the case of angiotensin II's renal drug-induced renal injuries, because it's actually going to decrease this system. Now, our body will try to maintain this perfusion as long as we can, but this compensation can only last so long, and eventually we're going to have a decrease in the amount of fluid getting into the glomerulus, and thus leading to a prerenal AKI. Again, these are hypoperfusion problems. And though there are many different causes of prerenal AKIs, one thing we can have consistently is some of the signs and symptoms. So, signs and symptoms of prerenal AKIs can include decreased urine output, concentrated urine, and then the other complaints may be dependent on the etiology. And we'll talk about the etiologies here in a moment. On physical exam, this will also be dependent on etiology because it can either be hypovolemic or hypervolemic. And as we talk about the specific etiology, this will become a little bit more specific. And then finally, you have lab values. Most of these patients will have a BUN to serum creatinine ratio greater than 20, a urine sodium and FeNA, as we mentioned before, less than 20 and 1%, respectively, and then high urine-specific gravity. Now let's look at these etiologies so we can start thinking about what are the causes. Now, you will see some overlaps in these etiologies. You will have patients that are both volume depleted and hypotensive. You will have patients that are hypotensive in an edematous state. We will talk about how, though we're talking about each separately, you got to know that they can occur at the same time. But it's important for us to know exactly what causes each of these. So let's start out with volume depletion. This is like the hypovolemic causes. Then we have hypotension. This is low perfusion because of something like a shock, whether it be sepsis, anaphylactic shock, or neurogenic shock. Then you have edematous states. In these states, it's actually caused by third spacing and our heart not working well enough to perfuse the kidneys. And then finally, you have selective renal hypoperfusion. This is where there's some kind of low blood flow due to some kind of blockage or constriction at the renal arteries. In the next section, we'll start working through each of these individually and talk about how we identify them and how we treat them.